Hello everyone. This clip I will talk about the common organ-specific infections. The outline of this clip I will follow this order based on the organ system. Maybe in each system may be more than one infectious syndrome, but I select only the most common that you can find in clinical practice. So we start with the cardiovascular infections. I focus on infective endocarditis. Pneumonia, I will focus only on typical pneumonia. UTI, gastrointestinal and hepatobiliary tract infections, skin and soft tissue infections, and central nervous system infections. Many of these clinical syndromes you may learn from the other specialists. So, for all, I will talk in ID perspectives. Let's start with the first organ system, cardiovascular. I choose the infective endocarditis. This topic you may learn from the cardiologist, but in this clip, I will present my ID perspective. The further breathing material resource, you can find the guideline from the US and European guideline, ESC guideline. The latest version is 2015. And from the textbook, can read on the Mander Douglas Bennett infectious disease. So start with the clinical manifestation. Infective endocarditis have many symptoms with various mechanisms. The patient may come to you with just only fever, with our organ-specific symptoms. But if you focus on examination, you can hear the heart murmur. When the patient knows pre-existing heart disease, when you hear the murmur, it's considered the new murmur. But in some patients may have some congenital heart disease that have existing murmur, but when infected with infective endocarditis, so it's changing murmur from the baseline. All of this can be called as a symptom of endocarditis. This is the mechanism of the infectious process directly on the valve, through the cardiac complication, maybe using the murmur from the stenosis of the valve or regurgitation valve. Some mechanism is we call the vascular embolic event. The vegetation at the valve can throw the emboli to the distant organ, the brain, or in the spleen, or the skin. And from the vegetation, the bacteria or corrosive organisms in the blood, they travel in the blood vessel to the other organs such as spleen, or maybe bind with the antibody to form the immune complex and deposit in various organs and cause symptoms such as hematuria. Maybe the patient did not complain anything to you, but when you check their urine, you will see the red blood cell in urine. This is a clue for this syndrome of infective endocarditis. Splenomegaly is the signs that found in this symptom from the bacteremia and metastasis to the spleen. There are many skin signs that we can find in endocarditis. These three skin signs and one sign in the eye are classics in infective endocarditis, but it's not common as we see in the real life. Two signs about the Janeway lesion and splinter hemorrhage we call as a vascular phenomena. The Janeway lesion is a lesion found on the palms. It has not tender, small erythematous papules. while splinter hemorrhage is a longitudinal red brown hemorrhage under a nail. These two lesions we call as vascular phenomena, and the other we count as an immunological phenomena is an ocular nodes. This different from the genuine lesion that is tender, but it's like erythematous nodule like the vascular line of genuine lesions. So the differentiating feature is about the tender and not tender. And this is from the immunological phenomena, while genuine lesion is called as vascular phenomena. All three skin size you can see on the skin of the patient, but blood spots, it is a white central retinal hemorrhage that you can see with ophthalmoscope inspect in the eye of the patient. These four signs is maybe classic but not common to find. About the ocular node, we found only 6.7%. Genuine lesion, we found only 2.2%. Blood spot, 3%. But with the hemorrhage, you can find up to 40%. But it's not specific to endocarditis. You can find this sign in other disease. The criteria for diagnosis of endocarditis, we can use the clinical criteria, divide into the major criteria and minor criteria. Major criteria, we have two aspects. One is the microbiology. We talk about the blood culture. Typical microorganisms that cause infective endocarditis like this, just only two separate blood cultures is enough to diagnose them, fulfill this criteria. When you take the blood culture, we call one set, two set, three sets. One set is mean one venipuncture site, maybe 1 to 2 bottles. In US or other country in Europe, 2 bottles consisting of 1 aerobic blood culture and 1 anaerobic blood culture. But in our country, in many institutes, an anaerobic culture require specific incubator. So we don't do, it's not available in many microbiology labs. So most common using in real practice is one set is only 1 bottle, that aerobic culture. 2 venipuncture sites from the left arm and right arm is the most common method to collect. And the 20 milliliter of volume is a key to increase yield of positive blood culture. So only 2 sets of blood culture that use the same organism like this is adequate to fulfill this criteria. Many doctors may understand that when to diagnose infective endocarditis, we require 3 blood cultures. So they mostly take 3 blood cultures. But in fact, we require 3 out of 4 blood cultures. It's only not typical microorganisms. Other than most of positive blood culture from the bottle, another way is use the persistently positive blood culture. That means when you yield organism blood culture and in the next 12 hours you can collect again and use the same organism. We call this a persistent bacteremia. This can be used to fulfill the criteria about 1B. Some organisms that cannot be cultured, we can use serology, such as Coxiella bennetii that cause Q fever. It can culture on the artificial media, so we use the serology antibody titer to diagnose this endocarditis caused by this organism. About the imaging positive for endocarditis, the most common is vegetation, but in fact the other signs can be counted as imaging positive for endocarditis. This aspect you should learn from the cardiologist. This from echocardiogram, but the other imaging modality is the PET scan or CT. This is the major criteria. The minor criteria is based on the symptoms and signs. The first one is a predisposing heart condition or IVDU, such as heroin injection or cocaine or other drug addiction. Fever, as I told, that is a common sign. Vascular phenomena, you remember, is the Janeway lesion and sphincter hemorrhage. You want to know because if the patient have Janeway lesion and sphincter hemorrhage, two sides is counted in the same group of the vascular phenomena, so it's counted as only one minor criteria. But if the patient you see have the sphincter hemorrhage and osteitis, we can count as two minor criteria. This is an immunological phenomenon. The most common signs that the student can be missed is about glomerulonephritis, that they tell you that some patients have hematuria from the immune complex. So if the patient have the red blood cell in urine and you see the dysmorphic red cell with the hypertension, maybe this is a clue for the endocarditis. If the culture is not consistent with any one of the major criteria, we can count as minor criteria. So two major criteria can count as a definite IE and you can start treatment. Or one major and three minor criteria or five minor criteria. All of this is a clinical criteria that can count as definite IE and start treatment. The other is about possible IE, is a one major and one minor or three minor. Reject endocarditis when you found the alternative diagnosis or the arteritis. If you remember, the typical microorganism causing endocarditis, the first one is the Viridian group Streptococci. Viridian group Streptococci has a member of many species of the Streptococci. In our lab, we use the multitoph, so you can see many surprising names of the Streptococcus. In each species, they have many propensity to cause endocarditis. Streptococcus mutans is the highest propensity to cause the endocarditis, followed by Streptococcus bovis 1. So we can call it Scaleroticus because it changed the name for the recent years. But it doesn't mean the other Streptococcus cannot cause endocarditis. It also can cause endocarditis, such as could be Streptococci, Streptococcus agaricii. We found this as a causative organism for endocarditis more frequently in Thailand. When the blood culture is negative and the imaging criteria is fulfilled by finding the vegetation from the echo or anything else, some microorganisms cannot grow with conventional blood culture. So maybe we require the special media or serology. Do you remember Coxiella burnetii? Right? The other is the Brucella, Bartonella, Tophrima, Mycoplasma, Legionella, and fungi. The culture for bacteria may be negative if caused by these microorganisms. We can find this about 31%. But in fact, The most common cause of blood culture negative is not by this organism, but is a consequence of the previous antibiotic exposure. As I told you, the patient may present with a fever without exact cause of fever, so they can take antibiotic or over the counter at the clinic to take antibiotics before came to you. And when you take the culture may be negative because of antibiotics. The other cause is the fastidious bacteria or fungi that require specialized media, serological testing, or molecular testing like this. When the clinical suspicion of endocarditis, so we should consult the cardiologist to perform the echocardiogram. If the diagnosis by this type of lesion in the from the echocardiogram, so we can fulfill the imaging criteria. If the blood culture is positive, you can treat based on the organism and susceptibility. But if the blood culture is negative, we can use the serology, or you can ask about the epidemiological factor to guess the organism and test by molecular testing. This is the clue that you can guess the organism, such as for example, the classic is about dog or cat exposure. You can guess the Bartonella, Pastorella, contact with the contaminated mirror of infected farm animals. You can suspect Brucella or Coxiella. Homeless, Bartonella, you suspect Bartonella, like this. It's on this table you can find in the guideline from the USA. After diagnosing of infective endocarditis, while waiting for the culture result, you can start empirical therapy. The first thing that you should consider that the patient have prosthetic valve or not. If not, we can consider the community-acquired native valves. The regimen is consisting of ampicillin with coxsacillin, or oxacillin is based on availability of your in situ, with gentamicin. So we use 3-drug regimen. This is the dose, and if the patient have the penicillin allergy, you consider vancomycin instead of ampicillin and cloxacillin, also with gentamicin. The gentamicin we use in the single-dose regimen, once daily. If the patient have prosthetic valve, and from the imaging for or echocardiogram diagnosis of the prosthetic valve endocarditis, you consider this a nosocomial endocarditis. Or if the patient have implanted the heart prosthetic valve for less than 12 months, you can employ treatment with this regimen. Because this setting, the patient have the risk of MRSA infection. So we start with the vancomycin with gentamicin. The first, after you know the culture that not MRSA, you can change the regimen later. In this regimen, the rifampicin can only recommend only in this setting prosthetic valve and should be start 3 to 5 days later than vancomycin, because we expect the rifampicin to inhibit protein synthesis, reflect the inhibit biofilm that the pathogen produce to prevent antibiotic penetration. Finally, if the culture yield negative result, you should consult the ID specialist to guess the pathogen and further investigation and select the appropriate regimen. If the patient have implanted prosthetic valve more than 12 months, you can consider as the native valve. You should let the regimen similar to the community native valve like this. Okay, now when we know culture result that report the pathogen, you can use specific therapy against them. The first, MSSA for native fowls. This pathogen you can know by notice on the susceptibility report that report susceptible for oxacillin. You can use oxacillin, coxacillin, or flucoxacillin is up to availability of the agent. 12 scans per day divided in 4 to 6 doses for 4 to 6 weeks. Only one agent is enough. If previously for empirical therapy use gentamicin, you can withdraw now when you know that the cause is Staphylococcus aureus. Of course, the risk of renal toxicity is outweigh the benefit. Alternative therapy. You can use both clotrimazole and clindamycin, but the report of the susceptibility should susceptible to both agents. In contrast, if the patient have MISA or allergy to penicillin group, you should avoid the beta-lactams to use vancomycin instead. But if the patient just a minor reaction to penicillin, you can still use cephalosporin. I want you to know that if the positive pathogen is MSSA, beta-lactam is a better efficacy than the vancomycin. So try to use beta-lactam if it's MSSA. But for MISA, well, beta-lactam cannot be used for that. Okay. For prosthetic valve endocarditis caused by MSSA, you can still use the cloxacillin or oxacillin, but in the prosthetic valve, we recommend to use the rifampin and gentamicin. Rifampin we use with the same reason as the empirical therapy that to protect biofilm production, and gentamicin we recommend in this case, but use only in single dose daily to reduce renal toxicity. If the patient allergic to penicillin, I mean severe reaction, or the causative pathogen is MISA. In this case, you should use vancomycin instead with rifamycin and gentamicin similar to a regimen. Next pathogen is oral and digestive streptococci. This group includes Streptococcus group D or maybe Viridans group Streptococci. Overall, you should notice about the susceptibility first. If the MIC of the streptococci is less than 0.125, that means it's susceptible. You can use the penicillin in normal dose. It's about 12 to 18 million units per day, or amoxicillin or ceftriaxone, either one of these, for 4 weeks. If you use the monotherapy with this beta-lactam, the required duration is about 4 weeks. But if you add gentamicin or netumycin, both of, both of them are aminoglycosides. This can shorten duration to 2 weeks. If the patient allergic to beta-lactam, you have to use vancomycin instead. In this case, duration is required for 4 weeks. Finally, about the post-valve endocarditis from the susceptible digestive streptococci, duration should be extended to 6 weeks. However, if the oral digestive streptococci is resistant to penicillin, that MIC in range about the 0.25 to 2, Now, we recommend to use penicillin in high dose, 24 million units per day divided in 4 to 6 doses for 4 weeks, combined with the gentamicin once daily for only 2 weeks. Similar to previous regimen, that the positive valve should extend duration to 6 weeks. And the same with the beta-lactam allergic patient, you have to use vancomycin instead. The next pathogen I will talk about the Enterococcus. Firstly, you should consider beta-lactam and gentamicin. If ampicillin susceptible, you can use it with gentamicin. This duration guideline recommend 4 to 6 weeks for ampicillin and 2 to 6 weeks for gentamicin. But some experts recommend gentamicin for only 2 weeks due to nephrotoxicity. But the same for prosthetic valve, we recommend for 6 weeks. In general, we cannot use ceftriaxone for enterococcus, but for the infective endocarditis, due to the mechanism of saturation of PBP of the target of the beta-lactam, we can use combination ampicillin with ceftriaxone. In case of the patient that cannot use gentamicin due to chronic kidney dysfunction. Anyway, aminoglycoside, when you notice about the gentamicin, you should check your lab that the susceptibility of gentamicin, the lab should test about the high level aminoglycoside resistance. If they test this fashion and they report susceptible, so you can use gentamicin combination with ampicillin. But if this test reveal resistant, you cannot use gentamicin. It is the another scenario that you can use this combination instead of gentamicin. But anyway, if the patient have the allergic reaction to beta-lactam, anaphylaxis, or other serious reaction, in this case, you should use vancomycin. Previously, you know how to use the medication for infective endocarditis, but in some group of patients, the surgery may need to cure this condition. The first indication for surgery is the uncontrolled heart failure. If the obstruction from the valve is more severe to control with the medication, you should consult surgery or CVT to consider surgery or about valve replacement. This is the only indication that we consider emergency timing to consult for surgery. The other is about the urgent for or elective. The second indication is about the uncontrolled infection. Maybe the pathogen is a fungus that cannot control by the antibiotic or antifungus alone, or the region is not only vegetation, it's abscess, fistula, or really large vegetation that antibiotic cannot control it. The other is about the prosthetic valve that the antibiotic cannot penetrate the biofilm to attack the organism. The last indication for surgery is to prevent of embolism. It is many in detail. It's up to size of vegetation and the history of embolic phenomenon. So this is the three main issues for surgery. The other entity of the infective endocarditis is the left side. Endocarditis most common is occur on the left side, maybe mitral valve or aortic valve, but some setting is occur on the right side, such as tricuspid valve. About 5 to 10%. The risk account for this condition is about IVDA, intravenous drug abuse, or HIV immunosuppressed patient, and the most common organism for this setting is Staphylococcus aureus, and the common affected route is dry valve. The symptom may be the same, but we found more frequent about the multiple septic pulmonary emboli. Know that when the vegetation occur in the right side, when thromboemboli is thrown to the lung, right? The predictor of death is a large size of vegetation and the fungal as causative agent and low CD4 in HIV patient. Empirical treatments, we should avoid cover Staphylococcus aureus, about 2 week course of oxacillin with, I suggest don't need gentamicin. If you use oxacillin base, you can treat for 2 weeks, but if you use vancomycin, you cannot use about 2 week regimen duration because of limited bactericidal activity. As I said to you that in MSSA vancomycin, we consider it's inferior to the beta-lactam, and its poor penetration into vegetation. In with this following indication that you can use 2 weeks treatment for Staphylococcus aureus for the right side. The first is MSSA, good response to treatment, no metastatic site, no intra-extracardiac complication, not prosthetic valve, no other left side valve involvement, and not too large vegetation, and no suppression. If the patient fulfill criteria and the right side endocarditis, you can use 2 week regimen of proxacillin. Now we will talk about the prophylaxis for endocarditis. You may heard about when you to dentist or your relative or your friends come to dentist to do something about their teeth, and maybe dentist ask you about hair problem to consider antibiotic prevention of the endocarditis before dental procedure. We have the consideration like this. The first, you consider about the risk factor of the host. Only one, only one of these have the fulfill one criteria. Any positive valve, if the patient have previous episode of endocarditis, if the patient have congenital heart disease, cyanotic heart disease, or congenital heart disease that repair less than 6 months, if the patient have one of these, is fulfill about the risk of the host. And then only this we not is not adequate to consider to use for prophylaxis. When the patient have one of these, the next you should consider about the procedure. Only dental procedure about the manipulation of the gingival or polyapical region, such as tooth extraction, only that you have to use the antibiotic prophylaxis. So if the patient have one of these and absent of anyone, maybe the prophylaxis may no need. The other procedures such as endoscope, bronchoscope, gatoscope, delivery, cesarean section, no need to use antibiotic prophylaxis, even patient have this risk. Okay. The recommended antibiotic for patient have two criteria. We recommend amoxicillin or ampicillin 2 grams once single dose is enough. If the patient allergic to penicillin, you can use clindamycin instead, or cefalexin or ceftriaxone 1 gram. But in general, maybe dentists may not prescribe you about to this. Okay. The next system, we will talk about the pneumonia. Well, typical pneumonia such as community-acquired pneumonia or respirator-associated pneumonia, I think you should learn from the pulmonologist. So in this clip, I will focus only on typical pneumonia. Typical pneumonia. The word atypical, previously we first applied to viral cap, but now this entity of pneumonia that can caused by bacteria and virus. So when we use the word typical pneumonia today, we generally refer to about typical pneumonia that means lower pre-attack infection due to specific pathogen that are bacteria. The example, Mycoplasma pneumonia, Chlamydia pneumonia, these two are common of the cause of a typical pneumonia that you that you familiar with. Uh, the other include the Chlamydia cytosis, Francisella tularensis, Coxiella burnetii. Do you remember that? This is the positive pathogen of infective endocarditis that only died by serology that I mentioned it criteria of diagnosis endocarditis. And the last is a Legionnaire, that is the cause of pneumonia that can be severe. And about the last year, I I think about the mid-year that have news about mysterious pneumonia occur in Argentina. That finally they conclude that the mysterious pneumonia is caused by Legionnaire. The same with pathogen we talk today. This entity of a typical pneumonia may distinct by clinically and radiologically from the viral cap. The viral cap have a positive viral that you remember, influenza A, B, avian influenza, RSV, even a virus or rhinovirus that cause a common cold. This is most common cause of a typical pneumonia. The last, I think you know as well, is coronavirus that can cause typical. So typical pneumonia doesn't mean it's less severe than typical pneumonia. It's a wide range of entities. Okay. The guidelines that I recommend to further reading is the latest recommendation guideline of community-acquired pneumonia and from the respiratory care and the JAMA. You should know about one thing that about community-acquired pneumonia. It does not include emerging respiratory pathogens. For example, about the SARS-CoV-2 that have is considered as a new emerging pathogen. So the treatment or diagnosis may be different from that included in this guideline. Okay, in this guideline, maybe we it's talk about the both post both bacterial typical pneumonia and viral pneumonia. So viral pneumonia they talk about in general, but for emerging respiratory pathogen, you should focus on the new launch guideline from the institute that studied about that. And these two guidelines or any guideline about the commonly acquired pneumonia generally not include in the immunocompromising condition, such as the patient with HIV and present with pneumonia. So we don't apply this guideline to this patient. Okay, include the patient with the transplant patient present with pneumonia cannot apply with this guideline. When you encounter with a patient with clinical pneumonia, uh, in general, if the causative pathogen is bacterial pneumonia, they mostly have the only pulmonary feature are fever, productive cough, dyspnea, and you can diagnose difficult by sputum examination, or maybe the other symptom that the patient may have is a bacteremia. That if severe enough, such as Streptococcus pneumoniae, that may be the bacteremic pneumonia. But for the atypical pneumonia, mostly they have the extrapulmonary feature. You should look for two keys to determine the causative pathogen. The first is zoonotic contact history and patient, and for the vital sign that patient have relative bradycardia or not. If the patient don't have zoonotic contact history, so we discuss about three common organisms: is a mycoplasma, chlamydia, and original disease. The RB is mean relative bradycardia. In general, when patients have a fever, they should have the pulse rate, tachycardia, correlate with the degree of the fever. Like that, the patient have the low fever is about the 38.3 degrees Celsius. The pulse is shoot around the 110 beat per minute. And if the patient have the high fever, the pulse may be exceed to the 130 beat per minute. If the patient have the fever in degree like this, but the pulse is not much as expected, we can call they have the relative bradycardia. That most common cause in the intercellular organism. Maybe it's not it may be not sensitive, but it's specific for some pathogen. If the patient knows zoonotic contact history and they have relative bradycardia, original disease is more common than the other two. But if the patient has a zoonotic contact history, this history you should ask with specific question. For example, about the psittacosis is caused by the chlamydia psittaci that found in the animal like parrot, macaw. If the patient have exposure about this type of animal before the onset of symptoms, Q fever, that the disease caused by the Coxiella, that the same organism cause endocarditis, pneumonia, but this pathogen is more common than psittacosis, but it's underdiagnosed because we have to use specific lab to diagnose it. In the same, in this group, we have used the relative bradycardia to differentiate the disease. So this is a clue that I have provided to you to guess the pathogen by the history. And when you suspect this disease, you should ask the specific question like that. About the Virginia is about the environmental exposure such as the contaminated aerosol, air cooler, or hostile water supply. It is the classic setting that patients have pneumonia after go to the cruise travel and have the pneumonia at the that's a cluster of the pneumonia at the same exposure history. The mycoplasma maybe is have an outbreak in the close contact members such as in the household member and the dormitory in the school. In our country that well known about the melioidosis, this pneumonia, the patient may have in general the exposure to the organism from the soil, but we mostly we have the mnemonic about that. It's about the farmer. The patient come from the northeastern Thailand, but in fact this pathogen can be found all over the Thailand, not just only the northeastern territory. This is the melioidosis are not included in the first slide of the typical pneumonia because it's unique in some territory. Okay, now we will talk about the symptom and signs we can that we have to use to differentiate the three common organisms that cause typical pneumonia: Mycoplasma, Legionnaires, Chlamydia pneumonia. Among these, Legionnaires disease can cause more severe compared with the others. And the Mycoplasma, the most patients have QRI first and then progress to the and about the Chlamydia pneumoniae is quite milder. Sometimes you think it's a common cold, but it's slow propagation and recovery. Maybe the patient have a cough for many weeks or months. The first symptom is about the mental confusion that Legionnaire has a common about this, and but we found in some cases of mycoplasma. About the ear pain, it's about the bullous meningitis. Uh, the most patient with mycoplasma, some patients have a ear pain. That the classic signs of bullous meningitis, but it's rare condition. Mostly the patient have only ear pain, but ear pain is not common in other typical organism, right? Abdominal pain and diarrhea or gastrointestinal symptom is common in the Legionnaire disease. About the sign, the mycoplasma have skin signs such as erythema multiforme. This is the classic sign that you should look for the mycoplasma in the patient present with. But this sign can be found in the other infectious and non-infectious condition. Maybe it's a duct reaction, non-exudative pharyngitis. As I mentioned previously, that the Chlamydia the patient may have a mild and like common cold, but the classic symptom is the laryngitis. The patient may have a hoarseness or sinus tenderness. Uh, about the heart, the mycoplasma, some patients have the myocarditis or have heart block or pericarditis. So this is the when you see the patient with pneumonia, but symptom of pneumonia is not obvious, and the patient have the chest discomfort or something, or you perform the EKG and you see about the heart block or elevated cardiac enzyme, but the patient is not by the ischemic heart disease. So this type of symptom should be recognized. Relative bradycardia, as I mentioned in the last slide, that the Legionnaire is more common than the other. But this disease is severe that can be shock attention. About the Legionnaire disease is a severe form of infection caused by Legionnaire, but maybe the patient may present with a milder form called the Pontiac fever. This is a minor form of Legionnaire disease. It's like the flu-like illness, but more severe form is Legionnaire disease. So in summary, the Legionnaire disease may have a confusion, diarrhea, abdominal pain, and bradycardia, or maybe severe as septic shock. Okay, about the imaging, the mycoplasma show you by the patchy infiltration or in the key when you perform the CT or X-ray, you may see about the bronchial thickening, and the X-ray may be seems extensive than the well-being of the patient than physical examination. Patient may not so bad, but the film is all bad like that. This is the term called that the film is more severe than the patient looking. For the Legionnaire, the X-ray is a rapid, progressive, asymmetrical consolidation. It's like the severe pneumonia, typical, but the Chlamydophila is a circumscribed region. The other lab that differentiate three organisms about Legionnaire have the hyponatremia, phosphatemia, and elevated ACLT. This is a common found in this disease because it's severe than the other, right? The Legionnaire have the about the mycoplasma have some lab that should help you to recognize it is a hemoglobin hematocrit dissociation or proactinic positive. You can see from the CBC that the patient have not leukodissociative is not striking, but you see the hemoglobin hematocrit is not consistent. It's not associated. It have showed you dissociation. The mostly we consider that hematocrit is about the 3 times of the hemoglobin, but if the proportion is not as expected, we should suspect about the proacute positive, and you test it, and you can, if the patient present with anemia, it help to recognize this organism. So about the diagnosis and treatment, summarized in this table. Because these three organisms you cannot see from the gum stain. So when you send the gum stain in the typical case of pneumonia, cannot diagnose these three organisms. And it's difficult to culture. It requires specific media for culturing. So we suspect this organism by the clinical syndrome from the extrapulmonary feature and zoonotic history that I mentioned about that. Mycoplasma, about the proagglutinin. If you suspect it, you should send about the IgM titer for acute infection, and you can send the 4-4 rising IgG about 2 weeks apart from the seroconvalescence plasma. You can use the PCR from the sputum associated pathogen spatial media app if you are available about the culture technique. About the Legionnaire, you can use about the immunofluorescence staining to detect about the single titer more than 1 to 112 or 4-4 rising of IgG. During antigen test in the US, they have the during antigen test for Legionnaire, but only Legionnaire pneumophilia serotype 1 only that can positive in urine. The culture that requires specific media such as BCY agar, or you can use PCR to detect this organism. Some Legionnaire species such as Legionnaire migdalii, you can You can see it by acid fast stain. Chlamydia pneumoniae, yeah, it's the same as mycoplasma. We use serology or PCR to diagnose it. About the treatment, the three group of antibiotics that used to treat this organism is macrolide, quinolone, tetracycline. For mycoplasma, azithromycin for 5 days is enough. Maybe doxycycline is the same as the chlamydia, but the chlamydia you should azithromycin have the longest half-life, so 5 days is enough. But the other may be extended to 10 to 14 days. The Legionnaire, we recommend the quinolone more than the tetracycline, or maybe macrolide it still can be used. If the mild severity, such as contact fever, just the mild UI symptom, but you can diagnose Legionnaire by the serology or the PCR or from the outbreak. You can use azithromycin for 5 days or quinolone for 10 days. But if the Legionnaire disease that have severe azithromycin may extend to 5 to 7 days. The other cause of pneumonia, other than other typical pneumonia, is the pneumonia caused by the cardia. We can call disease or pulmonary carditis. This pathogen is aerobic adenomyocytes that we found them environment, and they can transmit to direct skin infection or infection. Transmit through skin irritation, maybe cause the skin infection by mycetoma if the patient or the cardiac lung across an in normal host pneumonia lives it's a consolidation. It looks like tuberculosis, but in the immunocompromised host, it may be disseminated infection into various organs. When you inspect them on the gram stain, it shows the gram-positive beaded filamentous branching rods, but it can partially positive acid fast staining. If you send about the acid fast stain, maybe it's negative staining, but you can also see about the filamentous that you suspect cardia is have to stain with partially acid fast again. The microbe will alert it, suspicious about that. And now we can identify the species of nocardia by the mass spectrometry. For mycetoma, we can treat with only bacterial monotherapy plus surgical treatment. And for immunocompromised or disseminated infection, we can treat protamosazole plus amikacin or ceftriaxone. If they record abscess in any organs, surgical medication. Duration treatment extend to 6 to 12 months and require monitor after cessation of treatment because some patients have after cessation of treatment and no role of primary prophylaxis in general. If you see pulmonary nocardiosis and maybe other organs or my host, maybe brain imaging is needed also to check about the brain abscess from this organism because the treatment duration may extend if CNS. About the pneumonia, this pathogen can cause cavitary formation pneumonia like the tuberculosis. It's called a subacute chronic that you can misunderstand that this is TB, chronic bacterial pneumonia that refractory to antibiotic treatment. Next, I will talk about the viral cap. The before the COVID era, the viral pneumonia that was burden is the influenza. This is a contagious viral infection. This may be seasonal epidemics winter or rainy season in Thailand, and they can affect any organ with variable degrees of severity. In general, in seasonal, it's not quite severe, mostly in the setting of pandemic. Know about the Spanish flu or the avian flu that many years ago. The birds may be the essential reservoir virus that accumulate the virus and mutation. One day when they cross species to the it's called the pandemic. It has many types of influenza, so try A, B, or C. The A can be subdivided into subgroups about the 16 chemokinin and 9 neuraminidase. A and B and C affect human and other animals, can be widespread, seasonal, and pandemic. This is the virus in the family Orthomyxoviridae. It's an enveloped virus that can be kept by alcohol outside the cell, and they use hemoglobin for attachment and test for replication and from the affected cell. If there mutation in the general, it's called genetic drift, that a minor antigen chain that can just localize out in some area or countries. But if the mutation is large scale, it's called antigenic shift caused by reassessment to the exchange about the fragmented gene and can cause epidemics or pandemics, like the avian flu, that some gene exchange from the bird that are reservoir of this virus and can cause species affect human. Because the human in generally not immune to this type of virus, so when it causes the infection disease is cause severe and spreading more than usual. About influenza, transmission is to sneezing, coughing, speaking, thinking is like COVID. Direct contact with infected patient, contact with contaminated objects, maybe viral or aerosols. When the patient gets sick, the clinical manifestation is acute onset. Incubation period may be less than 1 day. And unlike COVID, all cases of influenza have symptoms. Some COVID patients may be symptomatic, right? Maybe have systemic symptoms, high fever, chills, headache, severe myalgia, arthralgia, fatigue. URI symptom may be a little bit is a sore throat, rhinorrhea, and dry cough, maybe last for weeks. The others include red eyes and diarrhea. About the complication, maybe caused maybe not coincident by COVID, but some susceptible patient was maybe superimposed with secondary bacteria. Some patients that have an immune effect about the Rh syndrome or septic meningitis or Guillain-Barré syndrome. In the high risk of complication, maybe the extremely age, pregnancy, about the chronic heart, lung, and diabetes. Suppression, children that using ASA, aspirin, uh, some race may cause severe influenza. Some factor is like hygiene, right? The secondary infection caused by bacteria. Someone is Staphylococcus aureus, Streptococcus pneumoniae, maybe the other gram-negative bacilli. About diagnosis, we can use rapid antigen by the ATK for the so we can done by the throat swab or nasopharyngeal swab. Is use less time, but maybe sensitivity is not high enough. It's just only 70%, but very specific. For more sensitive tests, use RT-PCR like COVID from nasopharyngeal swab. It may be by longer time, but sensitive specificity. Culture may be done in some facilities. Yeah, about the treatment. In uncomplicated case, low risk for severe disease may be symptomatic enough, but in the high-risk patient, antiviral treatment. Previously, we used oral ozanimod or trade name is Tamiflu. It's a neuraminidase inhibitor for 5 days. This agent um, widely used past, but now we report about influenza that resistant to this drug. New drug is the last in this table. It's a baroxavir that's just take only once, but now it's high cost. But I have no idea about this agent, but as I know, it's uh, it easy to use because it's take only once and the symptom may shortening. This disease can be prevented by vaccine. Efficacy about 60% to the main purpose of vaccine is to do security in high-risk patients, but you can infect with the influenza uh, outside vaccine strain. It's like COVID, right? About the manage of seasonal flu, in the algorithm, you have signs symptom of influenza. You should test if if you severe enough and or high risk for severe disease. You should be admit and start treatment. But if not, can you can cessation of work and maybe symptomatic treatment of the high risk patient. So now we will talk about COVID-19, the disease that I think all of you know it well. Its first outbreak in China in December 2019. It's a pandemic. Uh, Only some disease that can cause pandemic in our world is one of that. It's but it's not the new type of virus. It's a only new virus in the previous family. It's an emerged coronavirus. It affects humans and animals. It in family Coronavidae. The corona is from the crown, the head by that is a beta coronavirus. This beta is not the same thing. The beta alpha, the variants of the corona, is not the same thing. The coronavirus previously is just called the URIs. Uh, we know it in the name about the HCoV 229E, HCoV, and R63. All of four the cause only URI. And for some genus that's called severe 3 syndrome, such as SARS-CoV-1, that's called SARS, is about 2003, and MERS-CoV that are epidemic about 2012, and the SARS-CoV-2. This virus is an enveloped single-strand RNA positive sense viruses. They have a spike protein that use it to bind with the human receptor, and many antibody target this structure. We think its origin in the bat, but transmit through intermediate hosts. But until now, we don't know what the exact species that are intermediate hosts now, and then to the human, and maybe some short transmission from humans to animals. The major transmission route is from droplet, sneezing, coughing, like influenza, indirect and direct contact, and aerosol in certain settings, such as aerosol generating procedure, CPR, or endotracheal tube. Is a high rate of mutation, so we have many variants now, and some variants that have caused health problem. We call it variant of concern. Variant of concerns, we we call it because it's maybe AC transmission or increased severity of illness, reduced neutralization of antibody, and reduced efficacy of antiviral or vaccines. So now we have many variants, alpha, beta, delta, gamma, but now the dominant variant is Omicron. For symptoms, the COVID-19 firstly manifests like the flu. It's just like COVID symptoms, but small and taste disorder, the anosmia or dysgeusia is the unique feature that different from influenza. Influenza don't have symptoms like this, but COVID-19 have this. In any way, this symptom can be found in other conditions other than COVID-19. And when you check the CBC, may be found lymphopenia may be found in some person. About the 1 week, the later weeks in the second week, some patient, the high-risk patient, will develop respiratory symptoms is severe, and the last phase, some patients have the hyperinflammation phase that may be developed to ARDS, in short cardiac failure or multi-organ failure. In the variant about the Delta or Alpha, we see the patient in this phase so much, but in the Omicron now, we found it's few. Maybe it's maybe to the patient or population may get vaccine for more, and the virus can reduce their severity to cause disease in humans. About the diagnosis. Previously, the first of emerging, we use the PCR because we have to identify the specific patient that for specific case to isolate to prevent transmission. So the reverse transcripted PCR was used for early detection, but the limitation is with this test is persists for months. So if your patient wants have a COVID-19 and positive RT-PCR, the positive test will persist for a long time. We can differentiate that they are active COVID or new infection. This when you correct specimen for perform RT-PCR is required nasopharyngeal swab, so it's high exposure of the specimen collector and the patient. That the specimen collector should use the PPE promptly. Maybe about the test, the striking tensor value can tell you about the quantity of the virus. You may know in the past that we use about the CT to determine that this is infectious or not, but it's just the inference from the study. It's not exactly tell how infectious the virus is. This test is maybe false negative. It's up to timing of the test. If the patient with very early disease, the test may be negative. And the technique of specimen collection. Antigen test. This set is common use right now because it's easy and not take time too much for results. We use to screening, and the patient maybe do it by themselves, and it's mostly correlated with the positive culture that may be inferred to the infectiousness. The turnaround time is about 5 to 13 minutes, and however, this test is high false negative if the virus is still low, the early disease. The next is the antibody test. It is mostly used for the cellular prevalence. It indicates that once you can use to infection with the COVID. But in some patients that have get the vaccine, we can find the antibody. So we should check that this antibody is designed for what. If designed for the spike, maybe from the vaccine, but if the antibody is for nuclear capsid, this refers to the past infection. This specimen is blood. It's also broad exposure to the lab to do this, but we not use antibody to diagnose this active infection. This graph it shows you that when in the time past, the RT-PCR will go positive and then positive for long, while the antigen test is delayed than RT-PCR to get positive, and then for just about this is a symptom onset, about 10 to 14 days it will decrease and then negative eventually. And viral culture, the graph is look like the same as the antigen, so that we use antigen test or ATK to reflect about the viral culture that may reflect to the infectiousness. It may correlate more than well than culture, well than PCR. So in the past, we use 10 days at the end of isolation, but maybe now and the future, maybe need we need to shorter time to isolation the patient. About the treatment, I based on the NIH from the US in the patient that does not require hospitalization or supplement oxygen, and they have the high risk progress of severe COVID-19. Option that you should use is a Nemateria lucerputonaria. This is the first choice, followed by remdesivir if the patient cannot take the oral medicine. And the alternative is a molnupiravir. And about the bebtelovimab, this is monoclonal antibody. This in this guideline may be changed in the future, but about especially antibody, monoclonal antibody, that you should check that about the variant that epidemic in your country in that time, that antibody is worked for it or not, because this antibody is designed for the specific variants. When the viral mutation, maybe the monoclonal antibody may not work for all. If the patient discharged from the hospital, may no need to take any medicines later. But in the patient that hospitalized and there's still no need supplement oxygen, the recommendation that is still the same medicine if the patient has the risk. And if the patient have supplement oxygen, now the remdesivir and dexamethasone take a role. If the patient require high flow or NIV, non-invasive ventilation, dexamethasone or plus remdesivir still have a role. But finalized when the patient came into the hyperinflammation phase, only drug that can work is only dexamethasone or plus IV tocilizumab. It's a interleukin-6 inhibitor, antibody to interleukin-6 to inhibit this cytokine that causes inflammation. So the COVID-19, until now, we know it more and more, and have many more that we to know that the patient that recovery from the COVID, some patients have persisting some symptoms, fatigue, dyspnea, or cough, or maybe hypoxemia or sleep disturbance, psychic disorder. So we can consider it's always a long COVID that have involved many organs, but in general, it's much take more than 3 months. And this is the schedule from the vaccine. In general, maybe this schedule may be changed up to the guideline or the evidence-based medicine at that time. But anyway, every patient should have the vaccine for COVID, at least the primary series about the mRNA vaccine for 2 doses, and the boost, the third dose in the 5 to 6 months. If the high-risk patient may be required 2 booster doses, and later after that is up to the guideline or the recommendation that you should follow it. So we will go to the next system. It's a urinary tract infection. This infection is quite common in the general practice, but maybe this over-diagnosis sometimes, because most doctor diagnose this condition by mainly on urinalysis. But in fact, this condition should based on clinical first, and then we should consider about the urinalysis and culture later. So I will focus on the asymptomatic bacteriuria and cystitis pyelonephritis. Now we will talk about the asymptomatic bacteriuria first. Um, in general, the other specimen we recommend to keep in the room temp, not fridge in the refrigerator, because it may inhibit the bacterial growth. But for the urine, we recommend to keep it in refrigerator, not keep in at room temperature for more than 30 minutes, because the urine is considered as the good media for bacterial growth. So if you leave urine at the room temp, the bacteria is overgrowth more that may lead to an infection. Uh, if possible, you should collect urine from midstream urine more than the catheterized urine. That maybe you can get the bacteria that colonize or that adhere on the urinary catheter. Because the diagnosis of the UTI we based on the culture that is a quantitative culture. That the amount of the bacterial growth in the urine affect the diagnosis. The bacteria that growth that large not enough that we consider too significant. And in general, if the patient no symptom, and should be screened for asymptomatic bacteriuria. That's why which one we will select to check urine culture if they have no symptom. The first is a pregnant woman. The pregnant women have a high risk of the develop pyelonephritis. And the other operation is that any patient will undergo endoscopic urologic procedure associated with the mucosal trauma, maybe the prostate biopsy, like that. In this setting, significant bacteriuria, we consider if the urine culture positive for organism more than 100,000 CFU per ml. For female, should have the two specimens and the same and should be the same species. But for male, only one specimen is enough. Then, if the patient have in this two group operation have the significant bacteriuria, you consider treat even they have no symptom. For pregnancy, as I told you, that about 2 to 7% of pregnant women occur the ASB, and treatment reduce the risk of pyelonephritis, preterm labor, and robust weight of infant. The recommended agent is nitrofurantoin, ampicillin, sulfaxacin. Duration is 4 to 7 days. For beta-lactam, maybe extend to 7 days. But for male that undergo urologic procedure, we treat because significant bacteriuria considered as a risk factor for development of febrile UTI after procedure. But you should target therapy more than endpoint treatment. So we should treatment target on this the culture result. We start treatment in 30 to 60 minutes before procedure, and only short course duration may be about 3 to 5 days after procedure. Then now we will talk about the symptomatic UTI. First, I will talk about the spectrum of the UTI. First is acute cystitis. This may be the inflammation of the bladder. The clinical is a dysuria, or more frequency, urgency, hematuria, or suprapubic pain. And if the infection is beyond the bladder, it goes to ureter into the kidney parenchyma, maybe considered is acute pyelonephritis. Patient may have the fever with chill, nausea, vomiting, frank pain, dysuria, and post-operative ankle tenderness. And maybe in this setting, the blood culture may be positive for the same organism. In acute cases, it's mostly it's not have the bacteremia. Okay. Investigation. Uh, Firstly, if the patient has a symptom like this that you suspect about the UTI, you check UA first. If the UA have the white blood cell more than 10 per hyperfills, we consider the pyuria. In contrast, if we start with the UA have pyuria, but the patient have no symptom like this, it's a asymptomatic pyuria. In fact, there's no need to treatment except the two population that I previously told that you should further take urine culture to consider treatment in the pregnancy and the patient or undergo urologic procedure. And in general, the female may have cystitis more common than male because of the anatomy that short urethra and it's near to the colon, to the anus. The first episode of cystitis in female, maybe you can ample treatment regardless of culture. But if you take the culture, it's not wrong. It's okay to do it, but it's no, but it's up to the policy of your ancestor. And if the patient is a complicated UTI, so you should further investigation. We consider complicated UTI if the UTI is occur in male, it have obstruction, it have the renal calculi or nephrolithiasis or polynephric abscess or emphysematous pyelonephritis. This should be suspect if you treat UTI for a while and patient is not respond. You should have the pain in the back pain or low back pain or frank pain. You should perform the imaging to detect this complication. For the male, the most common is the obstruction and nephrolithiasis. And in the diabetic patient, the common is about the emphysematous pyelonephritis. About treatment, for diagnosis, when urine culture yield more than 3 species, we consider that the contamination. For the Foley catheter tip, is no diagnostic value, so we should send the Foley catheter culture. Urine from urinary bag, in the patient that enduring urinary catheter, they have the Foley catheter connect from the urethra to the urine bag. We don't use urine from the urine bag to culture because, as I said, urine that live in the room at the room temp for a while, the bacteria may be overgrown to mislead the result. But if you suspect tuberculosis of the kidney or bladder, you should use the first void urine in the morning for more than 20 minutes for culture and request for mycobacterial culture. So for catheterized urine, the significant colony count in symptomatic UTI is more than 100 CFU per ml, and uncomplicated cystitis in female, we consider significant is more at least 1000 CFU per ml. And for uncomplicated pyelonephritis, we consider significant is more than 10,000 CFU per ml. This is have the many misunderstanding in among the doctor that significant urine is more than 100,000. At the same with significant asymptomatic bacteriuria in the previous slide, but in fact, if the patient have symptomatic UTI, the amount that considered significant is lower. So if the patient has a cystitis, the symptom of cystitis, and urine yield the E. coli more than only maybe just only 3,000, it's okay to to tell it caused the UTI, okay? Because the cystitis is only 1,000. And chronicated UTI, including UTI in male, we consider significant is more than 100,000. It's similar to the asymptomatic bacteriuria. So about the treatment, uh, in acute cystitis that no need to high concentration in renal parenchyma, we recommend to use the nitrofurantoin for 5 days, but this is not quite available in many hospital or clinic. Maybe in the hospital school. The other choice is the clotrimazole or Bactrim for 3 days, or maybe fosfomycin oral single dose. It's very convenient for the patient. It's just only single dose. But about the fluoroquinolone, because now the E. coli that resists to fluoroquinolone or ciprofloxacin, the most common agent for UTI, but E. coli is resistant in the or for this class very much about maybe 90% in some province. So we don't recommend to use quinolone as an empiric first. But if you know the culture that pathogen is susceptible to quinolone, you can use it. And just only 3 days is enough. Or you can use the aminoglycoside single dose if you know that the pathogen is resistant to ceftriaxone. But for acute pyelonephritis, nitrofurantoin and fosfomycin oral may be not adequate tissue concentration in the renal parenchyma. So we recommend to use ceftriaxone and maybe shift to the oral cefixime in the if the patient can eatable, or Bactrim 10 to 14 days up to susceptibility. And fluoroquinolone, if you know that it's susceptible, you can do this in the IV form the first and then shift to the oral for the 7 days. But if the patient resists to ceftriaxone or quinolone, you can use the carbapenem, such as ertapenem or carbapenem. The common pathogen we consider to UTI is the E. coli, you know that Encapsula proteus. And the proteus is have some proteus and capsula that cause UTI have some unique feature that if you see the urine pH, in general, urine pH in the patient with UTI mostly acidic. It's maybe less than 7, but it's more than 7, and you should look for about the calculi, or we can call stack-1 calculi that in the kidney that difficult to remove, and maybe the sort of recurrent UTI. Because these two species have the urease to change the ammonia in the urine to the ammonium and form the stone. Enterococcus faecalis is mostly colonized in urine in many times, but sometimes it's act as pathogen to cause disease. And this pathogen cannot do the ceftriaxone, so ampicillin is the first step of choice. And Staphylococcus saprophyticus, this is the Staphylococcus species that cause UTI in the sexually active women. So if we found this pathogen in the young woman with the symptomatic UTI, and the during Gram-Stain first report about the gram-positive cocci cluster, so we should consider about this pathogen that can use nitrofurantoin and fosfomycin or Bactrim. Okay, this is all about the UTI that I want you to know. Later, we will talk about the gastrointestinal and hepatobiliary tract infections. Uh, in this section, I will talk about the two common settings. First is the infectious diarrhea, and the other is about the abscess. For the infectious diarrhea, You may have heard the terms infective diarrhea or non-infective diarrhea and infectious diarrhea. Difference: infective diarrhea have the broad range of the term, in a broad range term. It's composed of the infectious diarrhea and food poisoning, and maybe some food poisoning not from um, in about the infection. Maybe the non-active diarrhea may caused by the other medical illness. Infectious diarrhea exactly is about, I mean, the acquire the infectious agent by ingestion the pathogen. But for the food poisoning, the patient may ingest only the microbial toxin, not ingest the whole the pathogen. No, okay. And about the food poisoning, have another spectrum that from the patient that ingest about the non-microbial toxin. This means the chemical, for example, about the infectious diarrhea, the common organism is a Vibrio, Shigella, Salmonella, ETEC or EHEC. I'm not sure you know about this abbreviation. ETEC is mean enterotoxicity E. coli and enterohemorrhagic E. coli. And about the microbial toxin, we can further divide to the enterotoxin, the toxin. This toxin may be found in the food, and the patient get it regardless of the microbial also be engaged or not. And about the non-microbial toxin is, for example, stromboli toxin or the chemical toxin from the heavy metal, arsenic like that. And the other diarrhea may be cause of non-infection, so that the irritable bowel syndrome, and diverticulitis, steatotoxicosis, and maybe from medication, even antibiotics. Only some of the infectious diarrhea that need antibiotic treatment, and the other, food poisoning or other medical illness, is no need for treatment. Incubation period after exposure to the onset of disease may guide the cause of diarrhea. If infectious diarrhea, it takes time about 6 to 48 hours. And about the microbial toxin, it's just only 2 to 6 hours. And non-microbial toxin is so fast as 1 to 48 hours. This is about the common food or foodborne poisoning that I tell you. When the patient take this kind of food, they just only take toxin, no pathogen, called the infective diarrhea of food poisoning. And if the patient take all the pathogen and then pathogen will invasion or produce toxin either, this way we call the infectious diarrhea. The common setting is about the unpasteurized milk or dairy products. This may be the Salmonella, Campylobacter, this Staphylococcus aureus toxin. This is some kind of enterotoxin in the Western style about the mayonnaise, ham like that. About the consumption of undercooked meat or poultry, Aztec is mean chicken toxin producing E. coli. Is common in beef that when you eat hamburger, the beef will not well cooked, right? It's just medium well like that have the not kill the bacteria, so you can get this Aztec and gut infectious diarrhea. Clostridium perfringens, Salmonella, Campylobacter, Yersinia, and other. The common in your question, mostly common is about the undercooked eggs that come from the Salmonella. You know that the Salmonella, when you have the odor like a ripened egg, is from the hydrogen sulfide produced by Salmonella. And the large shellfish, know that is come from the Vibrio, maybe the Corre or Parahemorrhagicus. maybe it's caused you about the hepatitis A, that a virus, not only bacteria. So this is the term that many doctors may be confused about diarrhea. About the infectious diarrhea, we can further divide to the watery diarrhea. That means patient merely absent of fever or just a fever or low-grade fever. And this is the large volume diarrhea that the patient has fecal incontinence. Patient may have a dehydration or hypovolemia. The other type is about the inflammatory diarrhea. This may be start with the watery diarrhea, but may with or without fever, and then later develop mucus body diarrhea. You should know about this because this category, the patient may be start with the watery first, and then develop the mucus body diarrhea. This type you may find the white blood cell in the stool. Bloody diarrhea. Some cases absence of fever at first presentation. The example is for EHEC and E. histolytica. This is about some kind of protozoa that if you see the patient the abdominal pain and diarrhea is not obvious, but you found the red blood cell in stool, you should recognize about this pathogen. And the other type is the patient that have the sepsis, and diarrhea is some part of sepsis. If the source of the sepsis is the intra-abdominal, maybe we call the primary sepsis with diarrhea. This is a water diarrhea, but no fecal incontinence, just an irritate from the sepsis. And patient may have the localized abdominal pain and peritoneal signs. For example, diverticulitis or peritonitis. But the systemic infection with diarrhea is mean the patient have the multi-organ involvement, and diarrhea is some part of systemic infection. For example, fever. This, in this setting, you can notice that fever which you may came before the bodily diarrhea. It contrasts to the primary, that bodily diarrhea and fever, abdominal pain may come together. And the systemic infection with diarrhea or secondary, patient not only have diarrhea, they have the extraintestinal manifestation. They have the bacterial acidosis, multi-organ, for example, leptospirosis. They have diarrhea, scrub typhus, malaria, and or some patients that have an elderly or multiple sclerosis disease such as diabetes, CKD, or cirrhosis, or immunocompromised. This patient may have the primary bacteremia without other side viral infection and have diarrhea is some part of sepsis. So you should differentiate these two conditions because these conditions almost require the antibiotic treatment. But this condition only some setting that have require antibiotic. In the this is based on the guideline of the IDSA or 2017. You see that the finding of this, you can guess the pathogen from the clinical setting. If the visible but in stool, you should think about the Aztec, Shigella, Salmonella, and fever. Fever is not highly discriminated of to some doctors say that the when patient have a fever, it's bacteria 100%, but it's not. Fever can be virus, can be bacteria. Many diarrhea in adult maybe have a rotavirus, but we don't test in all cases, so this can be under diagnosis. Abdominal pain or about the grocery bag in stool, you know that one symptom can have many pathogens to cause that, but if you combine it, just narrow down your scope of the pathogen. And some pathogen may have the sequelae or post-infectious phenomenon, such as the Guillain-Barré syndrome from Campylobacter or the other like this. The most classic setting, but not common, it's mostly found in children that the patient have the no fever but bloody diarrhea at the first, and then they develop complication. They develop complication, acute kidney injury, and pap smear show the Marfan picture. This is called the hemorrhagic uremic syndrome. This is caused by Aztec or Shigella dysentery pseudotyphus. This setting, the antibiotic is contraindicated because it rise the bacteria and cause the toxin release and cause this syndrome. So I summarize in this uh, cartoon animation, like if the patient have the fever, diarrhea of recent international travel, like a foreigner when come to Thailand and have diarrhea, or when you travel to the India or any country and have diarrhea, we can call this a traveler diarrhea. This you may send stool culture or may not. It's up to about the convenience and the availability to follow up. But stool is to send for culture is the only unformed stool. If the stool is normal, we don't send it for culture because it cannot interpret. And then you can empiric treatment with the as travel diarrhea, ciprofloxacin or azithromycin based on the local antibiogram. Unfortunately, Thailand, the cause of diarrhea is resist to ciprofloxacin for 90%. You can see this number in the journal that in the guideline that I previously told you. So azithromycin may be safe and only short course is convenient to take all of the course of the regimen. If there are clinical setting in the fever, abdominal pain, and have bloody diarrhea and have dysentery. Dysentery it means you cramping abdominal pain, but you bend your body. This setting should be sent for stool culture. It may be caused by the Shigella and the recommendation treatment is azithromycin, ciprofloxacin, or ceftriaxone. But if the patient has the body diarrhea but without fever, then you should suspect about the EHEC. You should send for stool culture and wait for the results. If not, if because the stool you have the E. coli in normal, right? So in the lab not report the E. coli in general. So if you suspect this pathogen EHEC, you should notify lab to test about this pathogen. But in fact, only some in hospital, in school hospital that can test about this pathogen. So you should caution that this condition not treated with antibiotic, but PET-US will occur after treat. But immunocompromised host with acute diarrhea, you should check about the stool culture and blood culture together. Maybe you should maybe the treatment you have to cover the typhoid or salmonella. Typhoid or salmonella is consists of salmonella typhi and paratyphi. We have another category of salmonella we call the non-typhoidal salmonella. It's salmonella other than typhi and paratyphi, such as salmonella parasuis, salmonella enteritis. Because this group of salmonella don't need to use the antibiotic. If the patient comes with a fever with bradycardia, copenia, or maybe the sepsis with diarrhea, it also should request about the stool culture and blood culture, and then you should cover the same group of organisms. This is may called the spectrum clinical syndrome of enteric fever. And the last, if the patient has a fever, diarrhea, and have the history of previous antibiotic use, you should think about the cervical infection. So you should test toxin, GDH antigen, or toxigenic culture as gold standard. It's up to your facility that have this or not, and treat with the vancomycin oral. See, in general, we administer vancomycin as an IV, but in this setting, we should prescribe as an oral vancomycin. So this is the summary of the first choice treatment or the when the you know the definite pathogen that we call the targeted treatment. For Campylobacter, you can use azithromycin. C. difficile, you use vancomycin. Non-typhoidal salmonella, as I told you, is not indicated in general. I mean that when you have a diarrhea and the stool culture yield the salmonella non-typhoidal, so this antibiotic should not be used because it prolongs the carrier state. You found this salmonella in your body for longer time. But we will treat this in only if the patient is neonates, elderly, or immunocompromised, or bacteremia, most common in the HIV, or the patient have the suppurative inflammation of the anal organ, such as endovascular or prosthetic joint infection. But for typhoidal salmonella, such as Salmonella typhi or paratyphi, this should be treated with ceftriaxone or ciprofloxacin up to the susceptibility test. And when the patient found salmonella and they work in the school or the sanitary, they should check about eradication before return to work. Shigella, the first choice is azithromycin, and the Vibrio, the first choice is doxycycline, and the Yersinia, first choice is cotrimazole. As I told you, it is the one abscess, very large abscess in the lilo. I have double wall size there. Yes, this is amoebic abscess, and it is multiple abscess, have some daughter, and have septation. Amoebic have septation like this because it have enzyme to lyse the septate. And it is from the meroidosis that have the micro abscess. It's very small and multiple, and mostly have the spiny. This is the birth target sign. It's a neck red sign. About the diagnosis, or maybe we can use serology about the his entamoeba histologica titer, or maybe you found cyst in stool. For pyogenic, maybe the if have the presence of bacteremia, blood culture may be positive, or if the abscess have the chance to drain, polluted material culture may be used organisms. From myelinosis that difficult to drain, uh, you may catch the pathogen by the blood culture positive. Interventional drainage for maybe we do if not respond to medical treatment, and for the large lesion that have tendency to rupture. For pathogenic, usually require drainage. So if you see the abscess from the pathogenic and you may know from the blood culture positive, you should consult the intervention or surgery to percutaneous drainage first. If not respond or not adequate, you should go open surgery drainage. But for myelinosis, as I told you, that it's way too small to drain. Mostly we use only medical treatment. Antimicrobial treatment for amoebic abscess, we use the metronidazole for 10 days and then poromomycin. But as I know, this drug is quite not available in many hospitals in Thailand. For pathogenic liver abscess, you can use the beta-lactam beta-tamase inhibitor such as promoxicraf or ampicillin sulbactam. The pathogen is resistant to cephalosporin. You can use the carbapenem or quinolone plus metronidazole. This is extend required duration about 4 to 6 weeks. And for melioidosis, you treat like the bacteremic melioidosis in general. You require the ceftazidime for 2 weeks and then chlorotrimazole for 12 to 20 weeks. It's up to clinical and radiological response. The next system is a skin and soft tissue infections. In this topic, I will focus around necrotizing fasciitis. It's not so common, but this condition is life-threatening if delayed diagnosis. To talk about skin and soft tissue infections, we will separate the infections by anatomical structure on the layer of skin. If the infection is on the cutaneous, such as the abscess, folliculitis, or carbuncle, or cutaneous abscess, it may be treated as OPD or raw antibiotics with some drainage, incision and drainage, or IND. And when the infection is go deep to the subcutaneous and go to the fascia and muscle and outer skin structure, maybe the patient had a systemic symptoms. So the term cellulitis is maybe sound confused at the first time you heard it, but this term is mean the infection of the subcutaneous layer and necrotizing fasciitis is more deeper and more extensive. If you know about if you can determine about the extension of the disease, the psoriasis or necrotizing fasciitis, in clinical setting, it may be difficult to differentiate two conditions. Next, we will guess the pathogen by the risk factors or exposure history of the patient. Like this, the patient have a diabetes, cirrhosis, neutropenia, or animal might. We can know the common pathogen from this table. The classic is about the psoriasis, and when the patient exposure to the seawater, we will suggest the cause is the Ribero vulnificus. And when the patient have dog bite, the pathogen is Capnocytophaga honeymosis or Pastera motocida, like the cat bite. According to the ADSA guideline in 2014, we classify management of this condition to non-purulent infections and purulent. Today, we will talk about the non-purulent necrotizing infection, and then they separate the severity by mild, moderate, and severe. If the mild to moderate, we can observe the extension of the skin and then try empirical treatment with antibiotics. And if you see the extension is progress rapidly, you should consider about the severe and consult the surgery to inspection and debridement. And empirical treatment should be prompt to suggest by the exposure history and risk factor. If you define the cause of pathogen, you should treat with the specific antibiotics. So is the table to approach. If the clinical symptom is swelling, erythema, and pain, and no systemic sign, so this easy to determine that it's psoriasis. And erysipelas, these two conditions can differentiate it by the margin of the lesion. If you can see the margin obviously, it's maybe it's erysipelas, and if you cannot see the margin of the lesion, it's considered as a psoriasis. Psoriasis that more severe or necrotizing fasciitis in early course is maybe the same. The patient has the systemic symptoms. Then you should imaging of the affected tissue or part of the skin enrollment that have gas or no gas in the tissue. And if the extension is so spread rapidly, you should consult to debridement and collection the specimen to determine the specific pathogen. Preliminary, you should know about the pathogen by the gram-stain. If the gram-positive lots, you should differentiate about the Clostridium or other species, maybe the Clostridium perfringens or Clostridium sodalii or any or else. And if the mixed aerobe and anaerobe, consider the necrotizing fasciitis type 1. But if the gram-stain show the gram-positive cocci is a necrotizing fasciitis type 2. The most common is the Streptococcus pyogenes or group A Streptococcus, followed by Staphylococcus aureus. If the gram-stain show gram-negative lot, we can call the necrotizing fasciitis type 3. Most common is the seawater exposure in the patient with cirrhosis. Most common pathogen is Aeromonas for freshwater exposure and Vibrio for saltwater exposure. This is an example of the necrotizing fasciitis that when patient have the deep tissue injury and minor trauma, that patient can sometimes cannot notice about this lesion, and then organism will invade from the minor trauma and cross the infection that make the ecchymosis or hemorrhagic like this. If you see this, can consult the surgery for development as soon as possible. Necrotizing fasciitis in common use, we can divide into two types, but in fact, maybe we can divide into four types. Type 1 is about the mixed organism, aerobe and anaerobe, and maybe not focus on the what pathogen is it, but it's a mixed organism. So for type 1 necrotizing, you should treat the antibiotic that cover aerobic and anaerobic. The risk factor is about the immunocompromised and abdominal surgery or perianal abscess. So the key for type 1 is the polymicrobial infection. Type 2 is the monomicrobial. Most common is a group A or group B hemolytic Staphylococcus. And the type 3 is a gram-negative. Often is a marine organism such as Vibrio aeromonas. The patient may exposure by the skin exposure or seafood ingestion. And type 4 is a positive as a fungus. About the treatment, you can follow this table. If you know about the mixed infection, you should cover anaerobic, maybe the Ertapenem, Meropenem, Cefotaxime, or Ceftriaxone, plus metronidazole or clindamycin. And for the Streptococcus, penicillin is already the best. You should plus clindamycin to neutralize toxin. For Staphylococcus aureus, you can use oxazoline, coxazoline, or cefazolin. If the MRSA, you should use the vancomycin. For Clostridium, you should use the penicillin plus clindamycin. And the Aeromonas, you can use about doxycycline plus the ciprofloxacin or ceftriaxone. Or sometimes we have the interesting question that when the Streptococcus show resistance to clindamycin, should we still use it? About the adjunctive antibiotic clindamycin, we use it because of our antitoxin effect, so we can use even the pathogen demonstrate resistance to this agent, and this agent can have an excellent tissue penetration. Now we come to the last system-based organ system, that is the central nervous system infections. I will talk only about the meningitis, encephalitis, and brain abscess. Some part of this issue you may learn from the gist. Firstly, we will talk about the meningitis. When you suspect of bacterial meningitis, I think you know about there are symptoms of this clinical syndrome. It's very fever, headache, alteration of vital status. If the patient suspect of meningitis, uh, you should check about the checklist about the immunocompromise or history of CNS disease. Maybe patient have the cerebral accident, have a new onset seizure, and you may examination for papilloma, then you should examine the patient that all cases with alteration of conscious. This sign you should use an ophthalmoscope to detect that. Altered consciousness or focal neurological deficits or delay in performance, and then you should consider about the lumbar puncture. If the patient have any of these conditions, they have a tendency to have the risk of brain herniation after LP. So you should check about the imaging first. Before that, the blood culture may be done immediately after you suspect. So you should done this first. That is guarantee that you have the specimen collection to determine pathogen before antibiotic initiation, because bacterial meningitis is considered as an urgency condition. So this condition we will give antibiotics before lumbar puncture. If you think CT will be delayed, it's up to your facility that CT can perform fast. Not in our hospital, some hospital CT can done fastly. You can consider blood culture and CT, then start LP after the result of the imaging. But blood culture and antibiotic should start without hesitation to suspect this condition. About the antimicrobial agent, you can guess by two ways. One is the clinical syndrome, and two by risk factor like this table. We have separate by the age group, and then immunocompromised status, and about the some specific situation. So back to the algorithm, if the next CT scan show no sign of risk of brain herniation, so you can done a lumbar puncture. But if the patient have no any of these conditions at first, you can blood culture and lumbar puncture at first before CT, and then you should give the antibiotics and CSF finding if show bacterial meningitis. So you treat based on gram-stain morphology, and then when the culture result your organism, you change to definite therapy. So again, if patient have any of these conditions, blood culture, antibiotic, then CT and LP. But if no this condition, blood culture, and lumbar puncture, and check about the, and you can, uh, and, and during standing for the gram-stain of the CDF or waiting for the result of CDF file, you can start the antimicrobial agent and then check about the CDF file and treat after that. About dexamethasone, we don't give it in case. Role of corticosteroid was about the meningitis. We have the patient have the inflammation of the meninges, so it's occur in the closed space that have the risk of brain herniation. So this to increase inflammation. We give this about not more than 30 minutes before or with first dose of antibiotics. The dose is about 20 milligram intravenous every 6 hours for 4 days. It reduces mortality for the pathogen at the 70%, to reduce hearing loss of step suits. So if you see about the morphology from CSF finding and you see gram-positive diplopyr oxide or gram-positive oxide short chain, that may be the step suits, you should have the dexamethasone with the first dose of antibiotics. About the CSF analysis, in general, the color of CSF is clear, pH is neutral, and pressure is about 6 to 25 of water. Glucose is a crucial marker of the bacterial meningitis. If the glucose is low, it's quite significant that it is a bacterial cause. If the glucose is normal, maybe slightly decreased, it may be the viral. The red blood cell, normally if you perform lumbar puncture without trauma or just a little bit, the cell is so not too much. If the red cell is high and you know that around you make a trauma during LP, the white blood cell count may be mislead, fall high. About the white blood cell, when you see, you should check about the differentiation count, that about the neutrophil monocyte predominant can help you to determine causative mechanism. It is the color of the CSF. It is normal, and and you see this maybe read, maybe not, if not from the trauma or maybe the intracranial hemorrhage. The number of tubes you should collect CSF for 3 to 4 tubes insert like container, and the first one you should use it for about the biochemical test, and the second tube for the culture or microbiological test to reduce contamination rate that mostly occur in the first tube. And the third tube is for the cytometry. I mean about the cytology of the white blood cell count. And volume, you should at least 1.5 to 1 milliliter for bacteria and maybe one more for mycobacteria and fungi. If you use this CSF to check about the gram sense, it's very loose and it's difficult to see the organism. So you shoot the centrifuge and then you shoot the sediment to stain with gram and check about that. This not like urine. About the CSF, if you keep for sending to the micrograph, not keep it in refrigerator, because most common pathogen for meningitis is sensitive to cold temperature. As I told you, you should check about the blood culture with the CSF culture together, because most organisms of meningitis can be isolated from the blood. So I will talk about the common cause of bacterial meningitis. The first one is the septicemia. The risk is about the B cell defect or CSF leak, bacillus scale fracture, or cochlear implant. This is also the list that the indication for pneumococcal vaccine. A meningitis caused by septicemia, the onset is very acute. It may be hours to few days. The onset is more than a week. This organism is less likely. Some patients may show about the adjacent infection, such as sinusitis, otitis media, or mastoiditis before the onset of meningitis syndrome. In the severe case, the patient may show the skin lesion, that the purpura fulminans, especially in the patient with asthenia with overwhelming sepsis. These organisms have the autolysis that sometimes when you send about the CSF culture, the lab may alarm you about the gram-positive from the gram sense, and then if the culture is alarmed and not and the lab officer not inoculate the culture into the media at that time, maybe the organism will autolysis and report culture no organism. And this when the lab report about the pneumonia, the MIC to determine about the susceptible to penicillin or ceftriaxone is different from meningitis and not meningitis. So you should check about this before use penicillin. For sepsis, the list is about the undercooked pork, digestion or handling. Maybe about the slaughter that handling about the pork in the slaughter may infect without eating. This is quite acute onset. The hearing loss is a hallmark of this organism, but not specific. Hearing loss may also occur in the pneumonia, and this syndrome may reduce by corticosteroid. Some extraneural involvement of this organism. Some patients will have rash, febrile fulminans like pneumonia, infective endocarditis, uveitis, and endophthalmitis, and some patients have the spondylolisthesis and toxic shock syndrome. For listeria, the list is about the elderly, CMI defects. This pathogen is quite subacute onset, maybe few days to weeks, and in some patients may have the seizure and focal deficits. This pathogen may have some unique feature that other than meningitis, they may involve the brain parenchyma or encephalitis. And if the classic case is occur in the brainstem, so we call rhombencephalitis. Patient may have the cranial palsy at the brainstem, ataxia, multiple cranial palsy, or nystagmus, or some patients have developed brainstem abscess. The one thing that you should know that this pathogen not susceptible to cephalosporin is the most common drug used to treat meningitis as empiric treatment. The next is a Neisseria meningitis. This mostly occurs in the children and young adults. Also, the risk is about the terminal complement deficiency that mostly is inherited or maybe congenital. Some other people that have a close contact household member maybe need prophylaxis to prevent the disease. This is a droplet transmission. This is also acute onset by the pneumonia, and some patients have a rash on extremity. It's a macula, here and in so fast in a few hours per day, 2 days. And when you know about the pathogen, you should give specific like this. If the Streptococcus pneumoniae, you should share about the penicillin AC accessible. Penicillin is our first choice. If not, ceftriaxone or cefalexin is the option for penicillin resistant septic. Listeria monocytogenes, first choice is ampicillin. This is, as I told you, that you cannot use ceftriaxone for this pathogen. Neisseria can use if it like pneumonia, check about the susceptible to penicillin. If susceptible, you can use it, but if not, use ceftriaxone. Streptococcus agaricus, B streptococci. This is like streptovirus that can use ampicillin. About the gram-negative, you can use the cephalosporin third generation. About the duration, for the Neisseria, 7 days is enough, and for the gram-positive cocci is about 10 to 14 days, and about the gram-positive about the Neisseria maybe more than 21 days or 2 weeks, like gram-negative baseline. This is the dose for meningitis. You should check that some dose, some agent should be increased dose more than usual dose for treat meningitis. Ceftriaxone normal use 2 gram every once daily, but for the meningitis, it requires 2 gram every 12 hours. This may be easy for you to remember. For gram-negative cocci is 7 days, and positive cocci is 14 days. For any bacilli is 21, so 7, 14, and 20. Next syndrome is encephalitis. This is the inflammation process of the brain parenchyma for meningitis, but meningitis, as discussed previously, is inflammation of the meninges. That's why we can detect it from the CSF, but encephalitis sometimes the CSF it seems normal because some inflammation cell may not show you in CSF. So the patient will have the fever, headache, and rigidity. If you have that in this setting, you should check about the meningitis syndrome. If yes, it's go to the previous algorithm I already mentioned, and this is the same that you should take about the blood culture or empirical antibiotics or acyclovir if you suspect about the encephalitis. You should check about the imaging. If you see the space occupying lesion that cause the brain herniation, you should consult surgery for decompression. And if not, you should further check about have the cranial nerve or intracranial abnormality. If you think AP have a benefit, you can do it. And check about the CDF profile for the viral. This is quite different from meningitis. The encephalitis commonly is viral as a main cause of pathogen. The first tier 1 of the organism that should be investigated is about the enterovirus, herpes simplex, varicella, West Nile virus, and HIV in the patient that have a risk. In the patient that show preocytosis or white cell in the CSF, you should think about the meningitis or empyema or abscess. But if the CSF don't show anything, consider about other, such as the CJD or other virus. But in fact, in the clinical practice, about 60% you cannot identify the etiologic agent. The cause may be the infection, autoimmune, or neuroplastic. But if the infection is caused, the predominantly is the virus. So we use the CSF, MRI, and for these data from this two modality determine the specific test for the CSF. This is the algorithm that use the symptom and the part of the brain involvement that can guess the cause of disease. The most common of the viral encephalitis is herpes simplex. For encephalitis, herpes simplex 1 is more common than herpes simplex 2, and the common site is the medial temporal lobe, and this is the few viral cause that have the antiviral treatment with acyclovir intravenous. The other classic case is the herpes virus 6 that commonly involve the temporal lobe and campus or limbics. And the drug of choice is the ganciclovir. The other virus that common in Asia is the Japanese encephalitis. This mostly occur in the young patient and have the high fever and no vaccination. Have this virus is have a peak as an amplifying host and mostly in the basal ganglion, thalamus. This is effective anti-treatment, so the treatment is a supportive treatment. About the brain abscess, this may be the sequelae of the encephalitis. Patient have the fever, headache, and focal neural deficits based on the location of the abscess and have a seizures. Pathogen, mostly we use the predisposing condition, like in this table. The most common is about the sinusitis and dental infection. In the some specific hosts, such as the HIV, toxoplasma or nocardia, may be the unique pathogen that you should recognize it. In general, you can use the ceftriaxone plus metronidazole if you don't know the pathogen, and duration is maybe 6 to 8 weeks. You should monitor late clinical response and radiological response. Surgical drainage is required when the large abscess site and or failure medical treatment. Steroid is indicated only when the patient has severe brain edema. So this is the overall of the organ-based infection that I talked to you today. There are many more infection on the system that I will don't throw in this clip. For cardiovascular, you should know about the catheter-related bacillus infection, pericarditis, about the respiratory system, aspiration pneumonia or web or emphysema. I think you may learn from the pulmonologist. The UTI, some patients that have the Foley catheter, some patients have a body catheter associated GI prostatitis. This is may learn from urologist. Epididymoorchitis in the gastrointestinal system. We have the gattitis, enterocolitis, spontaneous bacterial peritonitis, cholangitis. Some of these may learn from GI or the surgery. And necrotizing fasciitis, I talk about the NF, but cellulitis is also common. About the sinus infection, maybe some in fact we have another big group of the aseptic meningitis that caused by viral that we will talk describe, and the epidural abscess. So good luck for examination, and thank you to see this clip. I have a quote that about to gain knowledge, we must learn to ask the right question, and to get answer, we must act, not wait for answer to us. Thank you. Can have a question and ask me anytime you see, and maybe email to directly to me, and I will answer to that. Thank you very much.